Van Zant,
Here.
Hopper,
Here.
Webb.
I got it all tied together.
Okay, I believe we have a quorum. Moving on to the consent agenda. I'd like to group items 1 through 9 together unless anybody,
We could go all the way to 11 if you want.
No, I need to pull out number 2.
number 2. Okay,
If I'm on the right one, July 25th, yes.
okay, I'd like to make a motion that we approve items 1, 3, 4, 5, 6, 7, 8, 9, 10, and 11, excluding item number 2.
I'll second that motion. Because we took out 2, correct?
We took out item number 2.
Okay, yeah.
Okay, if we can call for a vote, please.
Lively,
Yes.
Van Zant,
Yes.
Hopper,
Yes.
Okay, motion carries. If at this time, if we could hear item number 2.
Do you want me to ask my question, or you want somebody to present it?
Ask your question.
Okay. Let's see here. Okay, now, just for clarification, on page 11, it's the Mangum Regional Medical Center Quality Assurance and Performance Improvement Committee. Okay, so that says on here 3/7/23. Is this a quarterly meeting? One of them that's a quarterly, so then that's why, okay. That answers one of that. Now, when we're talking down here on this HIPAA security officer appointment, is that this, that's actually like HIPAA, that's that the HIPAA. Okay, I thought it was something new getting thrown in there.
We have to appoint those
Okay,
annually.
yeah, it wasn't that, I just thought it was new initials on it, so I was gonna
Yes.
make sure I didn't have something.
This year's workbook has that on like a standing list, so I'll put it in there, it's easier to keep track.
Okay, sure. Let's see here.
I think on that, just to clarify, it's HIPAA, and I have this HIPPA.
Okay, that's what,
Yeah.
yeah, that, because I thought it was something.
A lot of
that
people make
changed.
that mistake.
Yeah,
So I think that's what the clarification.
that's what I was asking to make sure that wasn't something different.
Because
so.
it's the Health Information Portability Accountability Act.
Okay, well, we're good, we're good on that part. Okay, let me go on over. Okay, so then I had, question as far as, when we look at, this is page 13.
18 and 28.
Oh, 18
Yeah, I
to
don't think
28,
they have the
okay.
packet, so.
Gotcha, 18 to 28. Okay, so we're looking through here, and obviously there were some things that were highlighted, so then they stood out even a little bit more. What month was this all from?
So this is data from May.
May, okay,
That was reported in 18.
okay. All right, so then, and I wasn't here in June, so then this stuff was looked at in June, but needed to have some revisions. Okay, so, when we look over all that stuff, what's the reason for them to be, amended?
So on the initial report, they were missed, so we went back and revisited it, added on to the minutes before they were written.
Okay, cause I really think, I don't know, somebody else you might know better, that's probably the first time we've seen an amended set, so that was what, I was kinda curious about that. Now, up here, when it talks about, let's see. When I first read this, and I hope that I haven't read it wrong, the patient reports allegedly taking home drugs to ER nurse, so these drugs weren't taken home. Okay, they were taken, like, I guess they were brought from home? Okay, girl, all right, because that was making, I looked at that and I read over that twice and I thought, what the heck? Did they just set some pills down and, okay. Now let's look over these grievances that are on the same page. And it says that one was reported, for having a poor attitude post-visit. So, are we talking about clinic, or are we're just talking about hospital? Okay, so then what do they come back in on a post-visit on that for? Is that just something special?
So post-visit would be once they left. Maybe they call in, or they stop
Okay.
at the desk and say, hey, or, reach out to somebody after their
Okay.
visit's complete.
All right, so that's why we have that reported grievance. Well, I want to ask you, I see where it says they spoke to Daniel and staffing agency HR. So was that a staffing nurse that was supposedly the one in violation and wasn't being nice? So that's why that, okay, that's why they were consulted. And then, is that person still employed that the allegations were against? Okay, because obviously if they are, and that's a repeated behavior, we need to make sure that they're, they need to take care of our people. Doesn't matter if I like something, somebody else doesn't like something. We don't want anybody being treated unfairly and ugly, and that is just not acceptable with, because we're always hearing about this excellent patient care. Well, that's part of patient care, is it not? So we need to make sure that when people leave there, now I'll just say, I did have excellent patient care yesterday, and I reported it from a lady in the lab, and the best lab technician I've ever come across. So, yes, I wanted to definitely point that out. Now listen, where is all this data? Where did it talks about, and you talked about data, where is it submitted to? Where does it come from? And because you don't have to go around and get this, do you? Or does it come to you through other reports?
It all comes collectively into a workbook, and then this is minimized to present to you guys.
Okay.
Just the basic definition.
Okay, all right. Let's see. So we go over, and now I'm on 20 and 28. This was something that popped out at me. Suicide management, and it says 3 for the reporting period. For our small community, 3 in 1 month seems like that's extremely a large amount of somebody gonna try to, you don't think so?
Not really, especially
mental-
not in the current times that we
Okay,
live in.
well then that's really.
As many as court intervention mental health cases I do per year, that's really not that many.
Okay, well then my next thing was, do we have personnel that's on staff that's there to address those issues? Or do we just kinda, when they come in, we don't know what we're doing, and is there somebody there that's highly trained to deal
So-
solely with this?
Our suicide, it's the whole broad mental health spectrum.
Okay, sure.
So it's not just suicide, it's the whole broad spectrum. And we have a policy that outlines, in the event of X, Y, Z, this is what we do.
Okay,
And we follow the policy, and there's certain procedures that we go through based on patient needs.
okay. Well, good. That's good to know everybody's getting taken care of. Okay, let's see. Now, when we talk about, this is really for my information, I tried to even call the pharmacist, so I wouldn't have to ask this and take up time. But when it talks about this 167 for the reporting period after hours access, does that mean that once 4 or 5 or whatever somebody's shift is on, then we're going into the medicines and we're getting those out? Tell me what that means. When, after hours access, what does that mean? Is that weekend? I'm at
It's on
20.
page 20 under F.
There, correct?
Yeah, anytime the drug room tech is not there or the pharmacist is there, the drug room is still available, the charge
Mhm.
nurse has a key to it. If the med is not ready or available in our med dispense system, they can go in there and access those meds if the patient's care requires it.
Okay.
If you're emergent,
We can only
anything that's on
store so
standby.
much in our electronic inventory.
Right.
And we have the surplus that we need and the extra.
That just seems like a lot for no more patients than we have to have 167 after-hour access. I mean, I don't know, it may not be, but it just seems that way. I mean, you're nursing, so.
It usually, unless something has changed, anytime you go in there, it doesn't matter if you're getting an IV flush, you have to note that you were in the drug room and that you grabbed
Okay.
whatever you grabbed. So if they were out of flushes and they went in and grabbed 20 flushes, that would be one of the accesses.
Okay, well,
It's
so
not-
that would be 20 on the, okay, well,
So
that's good to know.
it's not that unusual to be in there that many times. It just depends on if the patient was admitted after hours and you had to go get all of their
Sure.
medications because none were stored, or if you just had
So
to go
then
in
if
on
somebody
an
had
emergency
10
situation and
medicines,
grab
then
a
you'd
kit
get
or whatever, yeah.
10 clicks on it.
So
Okay.
you could-
Well, that's understandable.
You could be in there multiple times a day or at night, you know,
Okay.
after 5
Like
o'clock,
I said,
whenever
I
he
was,
goes home.
had to get a hold of her.
Now,
to
each
explain
med
that.
doesn't account for.
Right, just every time you're in there.
Every time
Oh,
you go in
okay.
there, you know, if they could go in and get 20 meds, that's one access.
Oh,
I wanna
okay.
clarify that.
Yes, thank you, because I was thinking that's what made the numbers get up
No.
there so
Now,
high.
each med is law, but that's still only one access of drug.
Gotcha. Now then, I think that obviously the next highlighted point was the medication errors. This was listed last month as 4, but it was actually 14. Okay, well, that to me is alarming, but you know what? I just can't imagine how we can make that many errors and not kill somebody at some point. That's scary, to have 14 med errors, okay? It goes on and explains a little bit as to what some of these might be or what has happened. What kind of re-education have we done? Because, you know, my God, people can die from that, and it just doesn't seem acceptable to have that many med errors for no more patients than we normally see. So where's the explanation for what would cause that or why? And how are we gonna improve on that? Because there's a huge difference in 4 and 14. Now, 4 could kill somebody as well, but 14, wow.
So it looks like they were re-educated on the policy for taking out meds, probably taking out meds, of course, the 6 patient rights, as well.
Okay. And this, because we're seeing this revision, it actually happened in June at some point. What caused us to have to go back and amend these? I mean, what?
So after we did quality minute, or quality meeting to report the initial data, it was, like, wait a minute, these numbers aren't correct.
Okay.
So to go back and properly amend them, that's what we're doing.
Okay, so it could have been just a missed typo, or it just something overlooked, okay. You know, I look back and I know that we have heard for quite a while about excellent patient care, and so that's kind of concerning that we've heard that, and maybe we've been getting a sugar-coated version, and so did we get the real stuff this month? I mean, with this amendment?
There's no
So-
sugarcoating. You receive accurate reports every month.
Oh, okay.
Yeah. There was actually a process issue there that I encountered as one med variance. The pharmacy, according to their practices, had to account all 10. And there were no harm on any of the med variances. It could have been a documentation or process error. But at the end of the day, the patient received the care that they were supposed to receive. May not have had the appropriate documentation or process included.
Yeah. Now, is that held true for the one that didn't get their insulin?
No, that was an
That's
actual. med
different?
variance.
Okay, good. Because I'm thinking that'd be something pretty important. And all these other things that, given the wrong dose of, I know that, however you say, guaifenesin, I know that's what makes you hack up, and, I mean, so, but still, I mean, it's disconcerting, I think, to see that. All right.
So, kind of along those same lines, my question would be, you had mentioned a process error. So is that what some of these are? Was a processing error, like the system that was in place wasn't accurate?
The
And that
order-
attributed to these?
The transcription of the order was not accurate.
Okay,
The patient received the medication, it didn't look exactly like the order, so we adjusted the way the order was entered in on that particular dose. It's an uncommon dose that we use in our facility, and when that happened, the med dispense system did not recognize what was in our EHO the patient got the meds they were supposed to receive, it didn't jive correctly between the two electronic systems.
Okay.
But that's still a system and a process error.
Right.
And a potential, so we even count the potential for error.
Okay, so it's more along the lines of a near miss as opposed to because of the process error.
Yeah, I hate to use the near miss, it almost kind of uses some grace that I don't like to see in our practice.
Okay. My next question, on the controlled drug discrepancies, it says that there's 11 for the reporting period, and it was the same on the last report. Everything else usually has a corrective action. I don't see one of those here for the controlled substance issues. Is there one? Or like, bottom line, what was the discrepancies on the controlled substance?
Really, there's not a whole lot of, there's not a whole lot of definition to these. It's not a, meds are not missing. I did look at the numbers because they didn't necessarily look the same. It's not one of those red flag discrepancies, but I'm not sure, you looking for what her,
If they're doing count, and let's say you hit the 7 button, but you meant to hit the 8, that creates a discrepancy. You know, if we count 8 Phenergen and they accidentally punch a 7, we have to go back and amend that, it creates a discrepancy. So 11 out of the total number, I mean, you gotta remember, we're counting every med, every shift, so that's 2 times a day, every med that's in there. The number 11 represents a very small percentage of that total process.
Right, my bigger question was that there wasn't a corrective action plan, and there is on everything else, and that's why I was curious.
Well, if it were to reach the point that it would be an issue that we needed to correct, right there with that number and the discrepancies and the nature of those, it didn't seem like the corrective action would be appropriate.
But
It didn't reach that level.
how can we get 11 both times?
And this, it would be a coincidence in this.
But in my mind, coming up with the same identical numbers at such a small number would raise more red flags than having 15 versus 11 in one, you know, like coming up with that same exact number, to me, sounds all sorts of alarms in my head.
and I'll verify, like I said, I looked at the numbers, I think I called me with the
Have you ever seen exact numbers like that before?
I mean, it would be a very interesting coincidence to have it 11 both months, but I mean, I guess it's possible.
Okay. Can we go back longer and see if we have a more consistent issue? Like, and say, okay, what was our instances 6 months ago?
So this data is, now, where does it come from? Does it come from the pharmacy? Does it come from, okay.
So this
From
is
the
pharmacy
dispensing
data, respiratory data, respiratory.
Okay, so we don't normally see that kind of stuff.
It all flows from the individual department to this one.
Well, how about, we see back, let's just say this year, and see if we've got, what we've got going on, and if there seems to be a constant for any of that, so.
You know, I mean, it could be as simple as everybody's doing everything correct and the computer's not entering it correct, and we're coming up with some weird number.
I mean, I know people do count in a hurry because they're ready to get out and change shifts, and, you know, you could accidentally hit a 7 as opposed to an 8, but.
If you'll go back up, and I think we're still on page 21, I had circled, the trough. I looked up and I thought, okay, now it sounds like something that water would run through. Is that what it is? Okay. Gotcha. Because I was just like thrown off. It sounded like Daniel's feeding his animals.
And I know he
No, there's a peak and trough for that
Okay.
particular medication.
Yeah. Let's see, the only other thing that I know that I asked this to Daniel a long time back about the medication overrides, but what, okay, explain to me again what that means. Those 57 medication overrides.
Again, real soon, we're probably gonna come talk to you guys about changing our management system, because it and CPSI just do not get along. CPSI generates a population over a certain way, and MedDispense wants to see it a certain way. And in order to administer the med that we've been ordered, sometimes we have to go in and do an override on that particular med. Maybe the dosage or the available amount is not in the library for that MedDispense system, but we have to make sure the patient gets So we have to create that override and get a witness to verify if that's appropriate per the provider.
Okay.
We don't like, it's not optimal, and that's the reason I hope you guys
Okay.
are very accommodating when we come
Because,
in.
I mean, just doing a little bit of research, a lot of times it mentions for an override that it really ought to be, urgent, like somebody life or death kind of a thing, and I thought, well,
Sure.
57, surely we don't have 57 people out there ready to, I mean, they're life or death to be having overrides. But is that also like if the pharmacist isn't there, the tech and the pharmacy tech's not there, is that an override? And it's
No, not
counted,
necessarily.
okay.
Again, it's just a lack of, the two systems not communicating effectively.
Okay.
Now, we had some cost savings with both, it was necessary at the time, but as the hospital progresses and the contracts run out on med dispense, we're probably asking for a better system now that we have enhancements with CPSI, we'd like to make the same enhancements. Just a
Yeah.
preview of what's coming.
Well, I would, yeah, I don't, if that's gonna cut these med overrides and these other things down, I don't know why that would be a problem unless it's just, unless Robin says we can't have that much money.
Now, I will say that, that 50 is out of 11,000 opportunities. So,
11,000, you hit that medication 11,000 times in a month?
well, the total number of medications dispensed for the reporting period of June was 11,035.
Okay.
Out of those 11,035, we had to override and then 50.
Okay, it's probably in the way that it's worded and that it looks insane to me, you know, so I just really needed that little bit of clarification on it.
Now,
Okay.
going back to the numbers, we have had a repeat, June and January were both 10. Well, I have 10 on here, you have 11? Not to take up too much time, we might as well
That's
answer this
all right.
question.
Well, yeah, that's good.
Yeah, I was actually.
And in March and April, we had 6. So it does occur sometimes.
Well, yeah,
that you
that's a
have
little odd.
Same number. 10, 4, 6, 6, 11, and 10. That's the discrepancies you were asking about, correct? You want to look back and see if there was.
On the controlled drugs?
Yes.
Yeah. Which one was 10? Because I'm looking at 11 right here on this.
My copy data shows 10 for the month of June.
Oh, we don't,
You may be looking at 11 for May.
Yes.
If it's-
Oh.
if it's- So you have,
Okay.
you have 10, 4, 6, 6, and 11.
Okay.
okay, so this is May report?
So there was a quarterly information.
That
Okay,
is
so this is a quarterly thing as well?
May's data for June's following.
Okay,
So it's always a month behind.
Okay.
okay, so y'all wouldn't have had one in July?
So we're looking at 2 months behind on the quality, really.
Because we have our meeting
Okay.
minutes, and then we have to approve them next month. and then
Yeah.
Yeah, I can see why that's, I mean, you're running 2 months. It's kinda hard to correct something, I guess it'll go on for quite a while, it's kinda like my travel, if you're doing something wrong, you're doing it for 3 months before they ever let you know. So,
But I mean, these like errors are being caught immediately, like, and we're taking course reaction
Oh, yeah, you have to-
that
you have to
day.
address it in real time.
Yeah, so it's being addressed in real time, we're not waiting for the quality meeting, but then it's being fixed and
You
handled,
can't
but,
move past that if there's a discrepancy.
yeah, okay, cool,
You have to
Everything
resolve
on
that
the
before you
quality
move.
is taken care of in real time.
okay.
So,
You guys are just reviewing what quality measures were in place, perfect.
so we come back at the end of the month and review, okay, we had so many complaints or what net errors, we review it then, but it's all taken care of in real time.
I think the only thing I had left was, I'm gonna assume that when we start looking at page 24, under the human resources and staffing, that termed means 5 were, terminated? Is that what that means?
Either voluntarily or involuntarily.
Okay.
They grouped them all together.
Okay, all right, so some people left on their own, some people might have been on COBA leave. All righty.
Previously, they were split.
Right, okay. Anybody else?
Nothing Nothing from me.
Nothing from me. I'd like to make a motion that we approve item number 2.
I will second your motion.
We can call for a vote at this time,
Okay, well,
please.
hang on just a minute though. Let's go back to these med errors. Those 14 have all been accounted for, taken care of, somebody educated on so that that's not gonna happen again?
They've all been educated, they've all acknowledged that they understand it, they understand the expectation. Can I promise that it won't happen again?
Oh, no, no. That's unheard
They haven't thoroughly
of.
educated.
Absurd to even consider that, but yeah. Okay, that's a lot better. Okay. Okay. All right now.
Okay. We have a motion. Can we call for a vote at this time?
Lively,
Yes.
Haskell, I'm sorry, Van Zant,
Yes.
Hopper,
Yes.
Moving on to item number 12, the June financial reports.
All right. All right. So in front of you, as usual, you should see the June financial packet. To start off for the month, we have an average daily census of just about 10 and a half, which year-to-date, that is our lowest month, but it only brings the year-to-date total to about 13 and a half, so we're still sitting at a roughly high census. On that same note, our inpatient Medicare utilization for the month dropped just a fraction of a percentage. Oh, I'm sorry, let me back up. It dropped slightly to 84%, but it only brought our year-to-date total just barely below 88%, which is still in line with prior years. Our cash receipts totaled roughly 1.8 million in receipts and 1.5 million in disbursements. Our operating cash at the end of the month was $627,000, and our cash reserve sitting about $964,000. And while I'm on the topic of the cash reserve, I wanted to go ahead and update the board. Last week we received a letter from Novitas regarding a interim rate review for the current fiscal year, and it did result in a payable due back the program of approximately $456,211. This is part of what we were anticipating. So after some discussion, decided we just needed to pull from the cash reserve, send that money back. That check was signed and mailed yesterday and today. So that has been overnighted on the way back. No ERS loan needs to be considered for this. But just a reminder that that was our first interim rate review. We will go through a secondary either in July for the period ending in July or August. So we'll have further updates on that going forward. Accounts receivable was down quite a bit, about $500,000 at the end of the month, but we can attribute this to the lower census. Again, this June was our lowest month to date. We did also conduct a semi-annual physical count. The resulting adjustments caused supply expense to increase $55,000 above our average. This is a standard process. We typically do a semi-annual count, and then we'll do another year-end physical count just to kind of bring things back into line. Our net patient revenue was almost a little over 1.3 million. Our 340B revenue increased to about 25,000, and this is reflective of increased referral captures. Our operating expenses were almost 1.5 million, resulting in a net loss for the month of 169,000. Additionally, in front of you, clinic financials have been provided. Our visits per day, year to date, are hovering at about 6.5. Revenue year-to-date, about 182,000. Expenses, 426,000, resulting in an estimated year-to-date loss of 244,000. And that'll wrap up my report. Does anyone have any questions?
Okay, when we look at the equalized rev ops, if we're expected to, pay them estimated $100,000, well, how much are we bringing in from them to be paying them that much?
I believe their contract is 5% of total receipts. So if our receipts, cash receipts go up for the month, the fee for RevOps goes up. If it goes down correspondingly.
Now, are they collecting every single penny that's coming in and getting 5% on top of that, or is this just bad debt?
I'm not sure I understand your question.
Okay, if they're getting 5%,
Mm-hmm.
are we talking about every single dollar that comes in? they're getting
No,
5%?
patient AR.
Okay.
So any, what we call non-AR receipts, like the 340B or SHOP, or when we get lump sum receivables back from Novitas, those are nice. That's not factored into what they
Okay.
get. So it's strictly patient AR that they get 5% of.
That would be a heck of a lot of money to be getting 5% and it'd be $100,000.
June was almost 1.8. Is quite a bit.
Okay,
Mm-hmm.
well, that's good, but, well,
Yeah.
okay.
Any questions?
Don't know if this is the place to ask the question, but who do we pay for phone service at the clinic?
For phone service at the clinic, they should still be under the Nextiva, which, oh, Chad, you may need to help me out, because are we not transitioning away from Nextiva?
With Next TV, we were locked into a contract until the end of the year. We are proposing here probably in October, we'd like to request for a new phone system for the clinic and the hospital altogether. But if, due to the way the contract is wrote, if we were to try to leave them right now, we would still have to make a monthly payment to them no matter what for the rest of the year, so.
Even when the
we
phones
have
don't work?
Plans for a new system toward the end of the year.
So when the phones don't work,
We've been taken in with the current provider.
like, so today I called to make an appointment at the clinic and the phones were down, couldn't get through. Called the hospital, they said, hey, the phones are down.
Today's problem was due to the heat. The network at the clinic went down due to the firewall, where the firewall is in the clinic, it overheated. Due to excessive heat in there, so that's the reason why the clinic phone today was down.
Okay, as somebody who has been dealing with a lot of phone stuff lately, there should be 3 fail safes in it. On a I'm paying for like a $40 internet line, and there are 3 fail safes. How are there no fail safes?
That's just the way this was currently set up. We are working to put fail safes in. We just haven't got them put in yet right now at that
So
clinic.
when the internet goes down, the phones go down, and there is no backup for that. And is that
In
same?
that clinic right now, there is no.
Is that the same? Is that true for the hospital as well?
No, the hospital has different backups. There's 3 different vendors that we are currently using for failover. And there's 3 different forms of how the lines come into the hospital. So if one vendor has a problem, we fail over to another vendor.
This one's not, you can call in, but we can't call out, so it's got trouble too.
Okay, thank you.
Yep.
Okay, moving on to item number 13, unless anybody else has any more questions about finances. Okay, thank you. Discussion and possible action to approve CPSI and Bamboo Health Performance Interface.
So I can jump in on this one here too. So this is an interface for CPSI with Bamboo Health. This is part of our promoting interoperability for 2023. This is mandated for us. Bamboo Health is one that provides prescription drug monitoring program for access for data resources across state lines for the physicians. We have this at no cost. CPSI is waiving their initial interface cost fee for this.
Okay, so this right here deals with, like, if we're wanting to get, let's say somebody's abusing, hydrocodone or something like that. Is that on the, that's not on the list for anybody to write that up, is it? I mean, that's not a drug that a mid-level can prescribe, is it?
It would all depend on their certification.
Okay. Well, what's one that only an MD can do, or a DO? What's the medicine?
Just say one of those controlled meds.
Okay. So these control meds, do we even have anybody other than Dr. Shefatelli that could actually write these scripts?
We have a position
We do have other providers that can.
Oh, okay.
We have Dr. Lou.
And they're MDs or whatever, okay. I didn't even think we had an MD in the county. So where do they work through the ER, where do they work?
Dr. Ellie and Dr. Davenport, yes.
Okay.
And Dr. Blue is supervising physician for the clinic.
Okay. But technically, we don't have anybody, we can just go to the, clinic and say, hey, man, I got all this pain going on and I need these now. And they've come from Wellington, and that would be a way to check it, right? The system, is that what we're trying to avoid? But we shouldn't have that many because we don't have that many that can write those, you know?
For promoting interoperability, what we need to be able to do is transmit, say Cindy is one of Amy's patients. Amy says, hey, Cindy came to the ER, I need that record. Basically, I can securely send it to Amy, and Amy needs it her as well. As part of that promoting interoperability, and we get points for usabilities, and more points for security. I think some of the other clinics are doing that, or other hospitals are doing that with your clinic provider and helps with administration.
Okay, so it's not just about those kind of drugs then? Okay, gotcha.
I'd like to make a motion that we approve item number 13. If we can call for a vote?
Lucky,
Yes.
Benjamin,
Yes.
Hopper,
Yes.
Motion carries. Moving on to item number 14, discussion and possible action to approve CPSI and Lab Corp performance interface.
This is another interface with CPSI and LabCorp. This is just, this is the bi-directional, so information will transfer from LabCorp through CPSI to transmit lab order results to be processed by LabCorp. This will help better the workflow for the lab, improve the efficiency of them. This one has no cost as well.
Make a motion, do you accept that?
I will happily second that motion. If we can call for a vote, please.
Lively,
Yes.
Van Zandt,
Yes.
Hopper,
Yes.
Moving on to item number 15, discussion and possible action to approve MRMC LabCorp interface system agreement.
Chad, did you get that one?
Which one is this one?
This is MRMC and LabCorp Interface System Agreement number 15 on the agenda.
Okay, I think this, yeah, this is from LabCorp, it's the same, the other one was for CPSI to LabCorp, this is for LabCorp coming back to the hospital. This is the other end, so when you have an interface, you have an interface on each side, so this is just LabCorp's interface coming back to us.
Now, this one's gonna cost $600 a month. 600 a month? Am I reading that
I
right?
think
No,
we're off one. I think that'll be the next one.
Oh, okay.
no, this one's 75.
Oh, okay.
Yes.
Oh, I'm sorry, I'm off one, yep. I'd like to make a motion that we approve.
I will second it.
If we can call for a vote.
Lively,
Yes.
Van Zandt,
Yes.
Hopper,
Yes.
Okay, moving on to item number 16, discussion and possible action to approve Port 53 Technologies, a quote for, yeah, okay.
So this is penetration testing, which is also known as pen testing. This is where we simulate a cyber attack on the network to check for exploitable vulnerabilities. With the way the world is now, as far as security, we feel like it's something that we need to be doing pen testing, just to check to make sure that we don't have any holes or anything out there exposing us to the outside world. I know one thing too, I read a report today that, for this year, there's already been over 330 breaches, affected 43 million people, which is already getting close to what all of last year was. And the average cost of a healthcare data breach is $11 million per breach. So, and I know on this right here, it says $600 per month, that's actually a misprint. For Mangum, it's a one-time fee of $480, and that's for 1 year.
And what all service will they provide other than testing your network? Like, are they gonna provide any fixes? Are they gonna assist you in fixing it?
Now, this is just a test, that we're on a pen test on the network, and it will tell us what our vulnerabilities are, and then it will be up to us to fix those.
So say that they do a test and they give you recommendations to fix whatever weak spots you have, and then you fix those. Will they retest to see if that worked?
Yes, this will be a test every month for 12 months.
Okay.
This is a 1 year deal, so every month we'll do a test on our network from the outside. This will test the clinic, the hospital, and then it'll give us the results as far as if we had any vulnerabilities. And then if we find a vulnerability, then we will go back through and fix the vulnerability, and then we can do a retest to verify it's been fixed, and then the next month we test again.
Okay.
Okay, so item number 16 states that Port 53 Pen Test Unlimited is 120. We're doing it 25 times for a total of $3,000.
So what that is, this is a corporate agreement. So corporate is getting the agreement for $3,000 for 25. So it's $125 per address, and you guys have 4 addresses. So that's the reason why the amount is only $480 for you guys, because you only have 4 addresses. So it is $120 per address. And so that will the only thing will be charged back to Mangum will just be the $480. Another benefit to this is on your cybersecurity policy that every hospital has. One of the big questions is they ask if we do pen testing. So this should have an effect on our rates when we do our renewal in, I think it's like October or November.
You good? No? Okay.
Carson, it's set up through cohesive for cost savings.
Just to be real blunt, what I don't like is, it looks like, to me, when I read the motion, that we would approve $600 a month, per month. There's a pretty big discrepancy in what we're approving and what we're saying.
Yeah, this was a typo in the summary, on the summary sheet. Instead of the 600 per month, it should be 480 a year.
Yes. And then moving down, where I understand what we're saying is, moving on the item number 18, I believe it was, it then says 3,000. You know, and it may be nothing to anybody else, but to me, it looks like we're approving $3,000 of expenditures at $600 a month, which still doesn't add up.
So you want that to come back and be stated correctly? Is that what you need? You know, what else will it say? Should be right with it.
I, to be honest with you, yeah, like, I mean, I think that should be, I think it should be tabled, it shouldn't, and then just represented with the 480 at the correct deal. I mean, I want it done, I think it's great,
Yeah.
but on the other hand, it doesn't reflect what's in what we're doing. So, just to be real blunt, Chad, is there like gonna be a huge problem if we table this? Is there any repercussions to us tabling this a month?
No, we can table for a month, if that's what you guys want to do. The only thing is, we just wouldn't move forward with like testing, like Mangum would not even be a month later before you got tested. Or start your testing. If you guys approve of it next month, of course.
We've gone this long without it, I mean. Corey, let me ask you this, can we amend this and then sign it? Like, if we vote on, can we say, I would like to amend the contract to read 480 and then vote yes right now?
Yeah, I mean, yeah, I mean, you can,
So we could say, I would like to have item number 16 amended to say,
That
we will
we
pay
approve.
480 one time a deal, and then that would be what I would sign, right?
yeah.
And then, so, like, I would like to make a motion that we approve item number 16 with the amendment made to it stating that Mangum Regional Trust will pay $480 one time.
I'll second that.
If we can call for a vote.
Now, is that one time or annual? I'm understanding this is an annual. We look at them every year. I hate for it to drop off next year and not have any
Termination
protection.
in a year.
What's that?
It's
Terminates in a year.
It's for 1 year, so next year we kind of renew it, then we'll come back to board and resubmit.
Thank you for clarifying.
Okay.
Yes.
Van Zant,
Yes.
Hopper,
Yes.
Okay, moving on to item number 16. Discussion and possible action to approve Central States Recovery Services Agreement.
Is that 17?
No, sorry, 17, yes. No, I'm off on everything, so.
Good evening, this is Chi, and I will be presenting this item. So the hospital currently uses Central States Recovery for collection services on unpaid account receivables over 120 days or older. So this agreement before you is for the Mangum Family Clinic to allow Central States Recovery to provide the same collection services for the clinic. The cost is the same, which is 25% on all amounts collected per account. And as of last resort, if litigation is commenced, the cost is 50% on all amounts collected per account. Once the agreement is signed, it comes into effect, and either party may terminate within 60 days prior written notice. Please let me know if you have any questions.
Why can we not do this ourselves? Why can this not be done in-house? And if they're gonna collect this money, then why do we, 50% of it to go to them?
Because people won't answer or, until you say I'm with a collections agency, it doesn't pay attention to them, and then they say I'm gonna ding your credit, so there's actual motivation to pay the bill.
But you can't do that.
well, not just that, but you need to cost for it, Medicare bad debts, and all the millions of hoops you have to jump through to show that you have done due diligence, to have collected, so you go to the collections agency, after so many days, so many statements, they consider your electrical, bring it in, and go in the cost report, and
And-
be reimbursed that way.
And if somebody states something wrong on a phone call, it can cost you a $10,000 fine.
So it really boils down to the cost report, how it affects the cost report.
That's a lot.
Okay.
Is there a way, when we go to the clinic, to amend the agreement to say that if I fail to pay, I will pay all collections fees?
Chi, do you know?
So currently the agreement with Central States Recovery, there is if litigation is commenced, then the charges go back to the patient, but for collection services prior to litigation, there's nothing that says that it will be billed to the patient.
What I'm saying is, can we easily just amend our form at the hospital, say, hey, that way we're not out the 25%? We cannot.
No, and I apologize, I don't
No,
remember. if
yeah.
I've asked that question.
Yeah.
and I
That's,
got told
yeah, you really can't do that.
Okay. Okay.
You can't make them pay prior?
To collect,
So if I go in there.
no, that's not what he's asking. He's saying that like if your bill is $100 and it goes to collection, your bill goes up to $125.
Because of their, okay.
And you can't do that.
Right.
Okay. I'd like to make a motion that we approve item number 17 unless anybody has any questions.
Okay, so this is solely for the clinic. And I'm wondering, how do you get, I was looking to try to find the stats on it, because you only had like 4 that were insurance pay maybe, and most of them were Medicare and Medicaid. And then you had some that were private pay. So we're talking about the private pay and the insurance people. That's who we're talking about?
I don't know, private pay.
Well,
It's on the insurance.
I think that's what it said on here was private pay. What, anybody know what page it is? So I can find
Yeah, let me
it?
take a look here.
But that's what we're talking about, not paying it, obviously, because the other ones would already go through a
Right, so
different
it's gone
system.
through the insurance collection cycle if they have insurance.
259,
Patient share.
260, and 261.
260 and 261. On the paper?
On the Central State Recovery.
Oh, okay, yeah, no, I was looking at something else.
Oh, okay.
Okay. Okay. Now, do we currently allow people to come in there with their insurance and not pay their co-pays or any of that?
I had to pay mine today.
I was gonna say, now, there was one time I came in, but their machine wasn't working. Could be related to the phone, I don't know, but, so.
It worked today,
I went the other day.
but I'm saying the phones were down today,
As
so.
you're saying, now, I had lab work and I had a copay, I'd never seen that before, is that new? That was at the hospital. So, okay. So, yay or nay?
I'm all about it.
Okay.
I'd like to make a motion that we approve item number 17.
I will second it.
Lively,
Yes?
Van Zandt,
Yes.
Hopper,
Yes.
Okay. Moving on to item number 18, the reaccrediting of Jeffrey Brandt.
Jeff Brand covers, ER shifts often, and this is just reproducing him.
Is it supposed to be executive session?
If we want to talk about anything about it, then we have to go into executive session.
Okay.
I mean, I don't have any problems.
Same.
Cool.
Okay. Do you want to?
No, no, like, I'm just not making the motion.
Oh, okay. Well, I'll make the motion that we re-credential, Jeffrey Brand.
I'll second it.
If we can call for a vote, please.
Lively,
Yes?
Van Zandt,
Yeah.
Hopper,
Yes.
Okay.
Pause for dramatic effect.
Yes, yes. Okay, moving on, staff and board remarks. I have a statement that I would like to make.
Can't make a statement, I want to remark.
Well, then I would have a remark that I would like to make. Or I'll tell you what, yeah, just go ahead. Yeah, we're cool. Okay, I'd like to make a motion that we end the meeting.
Well, I don't want to end because I want the remark.
I'll make it after we end the live.
Okay, I'll second the motion to end the meeting.
We're not gonna worry about new business.
Do we have any new business? You are correct. Okay, if we don't have any new business, then I'd like to make a motion that we end this meeting immediately.
I will again second the motion.
Okay, if we can call for a vote?
Lively,
Yes.
Van Zandt.
Yes.
Hopper,
Yes.